Now let's talk about the arteries. You guys, we reached the idea that once the axillary artery comes down below the teres major, we call it brachial artery. So the brachial artery will be in your brachium, in your arm. Now once you get down into the elbow, your brachial journey is going to end, and we will have two new bones. They are not called brachial bones, we call them ulna and radius. So that's why the brachial artery will divide into ulnar artery and radial artery. That's great, and we're going to talk about them in details when we reach the forearm. But I want to talk about the arterial supply, about the elbow joint. Now you guys have the brachium, the brachial artery, and the brachial artery wants to give blood supply to the elbow joint. People above needs to share, people below needs also to share. Now the brachial artery it's gonna give you two important blood vessels medially and two laterally, okay? And these two blood vessels need to unite with people coming from down to make an anastomotic network. What do we mean by anastomotic network? We need people fusing together and give a continuous flow, so that if a problem happens up, the one below can compensate, and if a problem happens down, the one above can compensate. So this is the anastomotic network we're talking about. Now, brachial artery wants to send blood vessel as a support at the side of the ulna. What do you want to call it? We will have one superior and one inferior. It will give superior ulnar collateral. Collateral means supportive circulation, and because it comes from above, we call it superior ulnar collateral, and it's gonna give one down, we call it inferior ulnar collateral. Why? Because both of them are at the ulnar side. And it's gonna give you laterally a radial collateral branch, and it's gonna give you an anterior branch from the deep brachial artery. From the deep brachial artery, we will give anterior branch, all right? It comes anteriorly, anterior to the lateral epicondyle of humerus, and it will give a radial collateral branch, radial collateral. So the brachial artery will give you superior and inferior ulnar collateral on the ulnar side, and the deep brachial artery will give you on the radial side one anterior. We call it radial recurrent. We call it radial collateral because it's a support, and anterior branch also. So the radial will be posteriorly and the anterior will be anteriorly. Now, the brachial artery will end at the cubital fossa as ulnar artery and radial artery. All right. Now the ulnar artery will give you recurrent arteries. What do we mean by recurrent? We mean that we are moving back. Although we are down, we are giving a branch that wants to come back and supply something that is before me. So we will call it ulnar recurrent. Ulnar because it's coming from the ulnar artery. So we have ulnar recurrent arteries, one anterior and one posterior. So the posterior one will fuse with the superior ulnar collateral, and the anterior will fuse with the inferior ulnar collateral. You will tell me, how can I remember that? Remember that the superior has the letter S, and the posterior ulnar recurrent has the letter S also. So the superior ulnar collateral of your brachial will unite with the posterior ulnar recurrent. So by now everyone knows when should we say collateral, when should we say recurrent. Collateral because it's not of brachial artery business to give supply to the elbow joint. It should be a job of the ulna. That's why it's saying I'm a collateral branch. I'm helping you out to the ulnar side. That's why this is the branch of brachial. And because the ulnar artery is already down and it's giving a branch that moves back, we call it recurrent. So that now you know the difference between the ulnar collateral and the ulnar recurrent. Now, from the brachial, you have superior and inferior. From the ulna, you have anterior and posterior. The posterior S and superior S, they will be together. And the opposite is true. The inferior ulnar collateral will be with the anterior ulnar recurrent. Now, what about laterally? You guys, the radial artery is not very important as the ulnar. It does not have anterior and posterior. It has only one recurrent artery will come out of the radial. So that one will go to be united with the anterior branch of the deep brachial artery. Okay, so that's perfect in the anterior part around the lateral epicondyle. What about the posterior? I have a radial recurrent artery who will fuse himself to me. Thanks to the common interosseous artery, there will be an artery called interosseous artery. That interosseous artery will give you recurrent branch. So thanks to ulna, ulna is not only gonna give you ulnar recurrent anterior and posterior, it will give you an interosseous branch, and that interosseous branch, we call it interosseous because it's between the two bones, and it will divide into anterior and posterior branches around the interosseous membrane. So that's why we call them anterior and posterior, and this is going to the interosseous area. That interosseous is gonna give a branch, and that branch we call it interosseous recurrent, and that will unite with the other branch of the profunda brachii artery. So that way we will have only one from the radial, we will have three from the ulnar. So down here we have 4 branches, and above here we have 4 branches, 2 from the brachial and 2 from the deep brachial arteries. All right, so this is regarding that. Now you guys, the brachial artery, like you saw, it was coming in front of the arm and the elbow joint. There could be, for any reason, a problem with the brachial artery that causes ischemia. One of them would be the supracondylar fracture, and this is the one of the most common causes. If there is a fracture, supracondylar fracture, that causes problem with the brachial artery, you will end up having a problem called Volkmann's ischemic contracture. So if you have an ischemic problem to the brachial artery for any region, for any reason, if that is fracture of, or if there is ischemia for any reason, that will cause Volkmann's ischemic contracture. In that case, you will have problem of all flexor muscles of your forearm and some extensor muscles. So that will end up giving you this signs and symptoms, which is flexion of interphalangeal joints, extension in the metacarpophalangeal joints, and flexion of the wrist. Okay, so mainly your problem is gonna happen in your hand and fingers muscles. Also your forearm will be affected, but mainly here, and this picture is a clinical picture of a very severe contracture. Actually, it doesn't start as such, it starts lighter than that. All right, so if you have a problem with brachial artery, you will have what we call the Volkmann's ischemic contracture. And one of the reasons for that would be the supracondylar fracture, but there can also be other reasons. Now we're moving to the cubital fossa. Here I want you to see how the cephalic vein goes all the way laterally and how the basilic comes medially, and then we have a vein that connects them together. We call it median cubital vein. All right, and this is the cephalic. It moves, like we said previously, in the deltopectoral groove, and it pierces the fascia here to drain into the axillary vein. So this is the cephalic, and here is the basilic, and the vein that connects them together is what you call the median cubital vein. Why medial cubital vein is important, we're going to talk about that, but I just want to show you how the cephalic comes all the way laterally and the basilic comes medially, and between them you have the medial cubital vein, and then the basilic moves on deep here all the way, and at that point we call it axillary vein, and it continues as axillary vein. All right, so this is a basilic vein, and that is the cephalic, and between them you have the medial cubital vein that they use it usually to withdraw blood and also inject any drugs. All right, here I wanted you to see the what exactly we talked about, the musculocutaneous before, and the median nerve. Yeah, the median nerve, it runs in the cubital fossa, and of course the ulnar is far away. The ulnar nerve moves behind the medial epicondyle and it enters the forearm. Ulnar nerve is outside the cubital fossa, but the median, it's in the middle, so it runs with the brachial artery. Brachial artery, median nerve, they are running inside the cubital fossa. So they are very important structures. Why? Because this is what we're going to talk about now. Okay, so I have here bones. I just want to talk about the cubital fossa first, and we can get back to the elbow. The cubital fossa, guys, you have it is made by an imaginary line between the two epicondyles of a humerus, and the lateral and medial borders by the pronator teres muscle, medially pronator teres, laterally brachioradialis, and then the meeting point between them that will make a triangular space. This triangular space has a roof, which is having the skin superficial structure and the bicipital aponeurosis. Remember that I told you the biceps has two tendons, one that goes to the subcutaneous and it makes the roof of the cubital fossa, and one that goes deep down in the cubital fossa itself and it attached to the radial tuberosity. So that is making the roof with the skin. And then the floor would be your supinator muscle and brachioradialis down there. Now the content is very important. You have the median nerve, brachial artery, and also the biceps tendon. And why is that important? Because this area, the medial cubital vein, guys, is in the in this area, and if you want to inject any drugs in the medial cubital vein, the nurse or the doctor needs to be very careful not to inject into the brachial artery, because it's one of the content, or the median nerve, because if you inject it into the brachial artery, you will have ischemic necrosis to the lower parts of your arm, and that happened. I saw a patient with that case in the clinics, and she had amputation of her hand because it kept on. She had a nurse who kept on injecting drugs into the brachial artery by mistake, and she wasn't knowledgeable and she didn't know about that. And after a couple of days, she found that her hand is getting darker and darker, and when she went, she found that all her cells have died, and she had ischemic necrosis of the hand. And that's why it's very important. We know that these are important structures, and that nurse should withdraw some blood and make sure that she's in the vein itself, because if she were in the brachial artery, there would be bleeding, because the artery has higher pressure. Anyway, so it's important to know that there is a brachial artery down there, and there is median nerve, because if they inject into the median nerve, that can cause loss of movements of the muscles, because that will cause hemiparesis and difficulty in moving the muscles. So it's very important to know the structures of the clinical cubital fossa, and this is superficial to deep dissection. This is how the median cubital vein here connecting the basilic medially and the cephalic laterally, and this is when you remove everything in the superficial parts, you get to see the bicipital aponeurosis, and then you get to see the brachial artery, and then median nerve, and then the tendon here. And if you go even deep down there, you will find that the brachial artery divides into ulnar and radial in the fossa itself, and it gives the radial recurrent above. The radial will continue the journey with us in the forearm. The ulnar will give you recurrent branches, and it will give you the interosseous. Interosseous, once it comes at the interosseous membrane, it will divide into anterior and posterior. So this is the ulnar artery. It will continue the journey down with us. This is the radial, and that was the brachial artery. That was a recap, and I just want to explain one last thing. In the elbow joint, you do have, we talked about the elbow, and in the elbow joint, you guys know that we have flexion extension, and that happens in the elbow joint. And you guys know what happens in the elbow bones. You know that the coronoid process rests in the coronoid fossa, and the radial head gets into radial fossa, and in extension the olecranon process gets into the olecranon fossa. This is flexion extension. And then you have pronation, supination, and that happens in the radioulnar joint. And the radioulnar joint is a joint between the radius and ulna. You have proximal and distal radioulnar joints. How will you remember it's between what and what? It's called radioulnar joint. So it's gonna be, the proximal one will take the first name. It's gonna be between the big boss, the radial head, and radial notch on ulna. Can you guys see? This is radial head, and this is radial notch on ulna. And the distal one, we're going to talk about it when we reach the hand, but it's going to be between the opposite ulnar head and the ulnar notch on radius. Okay, so the proximal, because it comes first, and because the name of the joint is radio-ulnar, so it's going to be between everything radial, radial head and radial notch on ulna, of ulna. Okay, radial head, radial notch of ulna. This is pronation, supination. And then you guys know that you have in the elbow joint, you have it's a hinge type of joint, and the condylar parts, the parts that makes the joint, are covered by hyaline cartilage. And also here you have the synovial membrane that lines this. So whenever you have a joint, you have a bony area, you have synovial membrane, and you have outside the capsule, you have fibrous membrane, and you have between them synovial fluid, because you want to make it easy for you to move. And because the fibrous connective tissue above will condensate outside and be supported by ligaments. So any joint we have, it has bony area. It has bony area that is lined by hyaline cartilage and covered by a synovial membrane, and then covered outside by fibrous connective tissue, inside covered by synovial membrane, and of course that was hyaline cartilage. And then that outside kind of fibrous connective tissue is going to condensate, and you will have ligaments that connects the bones together. So those ligaments that we have medial and lateral ones. We have the ulnar or medial collateral ligament that wants to attach the humerus to the ulna, and you have the radial that attach the humerus to the radius, and you have a very important ligament that wraps around the head of radius. If you guys can see, it moves around here, the head of radius. Here around the head of radius, we call it the annular ligament. Annular because it wraps in annular fashion, this ligament. And it's very important to keep the head of radius in position and prevent dislocation of the radius during movement. All right, with that, you guys, we are done. Thank you guys for watching, and see you.